Peyronie's disease is so much more than just a clinical diagnosis. For so many men, it's this deeply personal challenge that can really shake their identity, their self-esteem, and their relationships. And for doctors, well, it's a complex puzzle filled with some really tough treatment choices. So in this explainer, we're going to unpack that very dilemma. First up, we'll explore just how personal this condition is. Then, we'll dive into its two distinct phases, and understanding these is absolutely crucial for timing treatment correctly. We'll get to the heart of the debate: conservative therapy versus surgery. We'll also navigate the tough realities of what surgery actually involves. And finally, we'll look at some exciting new tech and find out why the only real answer is one that's totally personalized. So, to really get a handle on the treatment debate, we've got to start with the human cost. This condition goes way beyond the physical symptoms. It cuts deep, affecting mental health, how a man sees himself, and his most intimate relationships. This quote from the Global Andrology Forum, wow, it really gets to the heart of it, doesn't it? The psychological weight of this can be just immense, often leading to depression and anxiety. And you have to remember, so many men suffer in silence because they feel too embarrassed to even ask for help. And that number, 80%, it's just staggering. 80% of men with Peyronie's report this kind of distress. And it's not something that happens in a vacuum. It really impacts couples, with more than half of them saying it causes serious conflicts in their relationship, all stemming from the disease. Okay, so now let's switch gears a bit and look at the clinical side. Here's something you really need to get. Peyronie's disease isn't a static thing. It actually moves through two very different stages. And figuring out which phase a patient is in is everything when it comes to making the right call on treatment. So what are we talking about, really? At its core, Peyronie's is about this fibrous scar tissue, it's called plaque, forming inside the penis. And this plaque just doesn't stretch the way normal tissue does, which is what leads to that signature curve, the pain during erections, and sometimes a loss of length. It all starts with the acute phase. Think of this as the active inflammatory stage. There's pain, and the curve is still changing, still evolving. The main goal here is just managing the pain. But then it transitions into the chronic phase. At this point, the pain is usually gone, the plaque is hardened, and this is the most important part: the deformity is stable. That stability is the green light, the crucial signal that more definitive treatments can finally be considered. And that brings us right to this major crossroads where patients and their doctors are facing a huge decision. Do they stick with less invasive, conservative therapies, or is it finally time to think about a surgical solution? So the real key here is matching the right treatment to the right person at the right time. Conservative therapies, things like injections or traction devices, are often the first line of defense in that acute phase, or for less severe cases where intercourse is still possible. But when you're talking about severe, stable deformities that make intercourse impossible, that's when surgery really becomes the main option to try and restore function. Okay, so what's the real tipping point for surgery? What's that one thing that makes doctors say, okay, it's time? Well, it's pretty interesting because all the major urology associations across the globe, they all agree on one critical point. The answer, in one word: stability. That's it. Surgery is only on the table once the disease has entered that chronic, stable phase. And why is that? Well, if you operate during the active phase while things are still changing, you can end up with really poor results. So patience is absolutely essential. That curve has to be stable for at least 3 to 6 months before a surgeon will even consider it. But deciding to go for surgery is really just the beginning of the journey. The next, and maybe even harder part, is navigating this delicate balance between the benefits, the risks, and most importantly, the patient's expectations. Because when expectations don't line up with reality, that's where the trouble starts. So I want you to think about this for a second. After a surgery that perfectly corrects the curve, what do you think is the number one thing patients complain about long term? It's probably not what you're guessing. It's penile shortening. That's it. This is, hands down, the biggest cause of dissatisfaction after surgery, and it doesn't matter if it's a measurable, actual loss from the procedure or just a perceived loss. It's a massive concern that has to be talked about openly and very realistically before anyone makes a decision. And just look at this disconnect. It's huge. A doctor might objectively measure some length loss in, say, 18 to 41% of their cases. But how many patients feel like they've lost length? Up to 75%. That's a massive gap, and it's exactly why the pre-op counseling is every bit as important as the surgeon's skill with a scalpel. And then you've got this other huge factor to consider: Erectile dysfunction, or ED. It's a double whammy, really. Up to 58% of men with Peyronie's already have ED. For those who don't, some of the corrective surgeries actually carry a risk of causing it. So for those guys who are dealing with both a severe curve and ED, a penile prosthesis often becomes the most effective solution because it can fix both problems in one go. All right, let's shift our gaze forward a bit, because this field is always moving, and new innovations are changing the game, both in how we make decisions today and what treatments might be possible tomorrow. One of the biggest leaps forward is in how surgeons plan for these operations. You see, the old challenge was relying on, kind of fuzzy 2D photos and subjective eyeball estimates. But now, we're talking 3D photography and even AI-powered measurement tools that give incredibly precise, objective data. This means better surgical plans, and crucially, it helps everyone set those all-important realistic expectations right from the start. And looking even further ahead, the holy grail of research is really to tackle this thing at its biological source. Scientists are looking at these antifibrotic drugs that could, in theory, stop or maybe even reverse the scar tissue from forming in the first place. I mean, the ultimate goal is to one day manage this with medication and maybe avoid surgery altogether. So where does that leave us? After looking at all sides of this debate, what's the final verdict? Well, it turns out there's no winner in the fight between conservative and surgical therapy. The only best treatment is the one that's carefully, painstakingly tailored to the individual patient. So what are the big things to remember from all this? First off, treatment has to be matched to the phase of the disease, the severity of the curve, and whether ED is part of the picture. Second, that honest, realistic conversation about what to expect is just as critical as the surgery itself. Third, good, detailed documentation is non-negotiable. And finally, you absolutely have to address the psychological toll on both the patient and their partner. That's a huge part of the process.
Which really leaves us with this one last thought to ponder. For a condition that tangles up physical form, sexual function, and psychological well-being so completely, what's the best tool? Is it a scalpel, a syringe, or is it a conversation? The truth is, the answer is never just one thing. It's a combination of advanced medicine, precise skill, and most importantly, empathetic human communication.